Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the School of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome Dr. Christopher Snyder from Tidal Health Peninsula Regional. Thanks for coming in. You've been in before talking about COVID since this all started back in the February time, and here we are again to do another update. So thanks for coming in, and you are really up to date on things because you are the Chief Quality Officer at Tidal Health Peninsula Regional, and also you're the lead physician of the COVID response team.
Correct.
So I know you want to first start off with the fact that we do have a surge going on. That's the not so good news. But then there's plenty of good news you want to discuss about treatments and update on vaccines.
Yeah.
So let's first start off with where are we with the numbers in COVID-19?
Yeah, unfortunately, we're hospitalization-wise, we're about where we were in April of this year. So throughout the state, the hospitalization numbers, both Delaware and Maryland, are peaking out again. We've seen an increase in the last month that's been significant for hospitalizations. Good news is they're not quite as sick as they were. We don't have the ventilated patients or the volume of critical care needs. But that being said, we have a large volume of med-surg patients. Unfortunately, COVID patients, sometimes because of the treatment, sometimes because of the illness, tend to be in the hospital 6 to 7 days on average. So that's a pretty long length of stay in a hospital. We usually average about 3 to 4 days for most medical patients. So it's a bit challenging because we're filling up quickly. Resources are challenging right now. We have great PPE. We have a great facility. We're in a world where we are prepared. We have everything we need to manage COVID, but we have a lack of nurses. So we're very challenged with that, and our doctors are limited too. It's been a very difficult month. Just to get back into that mental mood of what we had to deal with in the spring. And a lot of us are still pretty beat up from that. So it's a tough time right now, but we're managing, we're getting people moved around, we're trying to isolate and utilizing the powerful hospital in the building we have over there to the best of our ability.
And they all are being kept in the Layfield Tower specifically, correct?
Yeah, our Layfield Tower is a negative pressure tower. So from the 5th floor all the way down to the basement. The basement was where we rebuilt that. We took our conference rooms and the wonderful community and team support of our environmental services and our building services rebuilt us an ICU down there. We've made a lot of modifications to that in preparation for what we're going through now. So good news is we changed it to make it better. Bad news is we might have to use it again. Currently, we're not using it, and we're trying to avoid that unless we really have to, because it's not designed for medical care like the building is upstairs. But the negative pressure is really important because there aren't too many hospitals in the world who have that type of facility where you can close a whole building off to negative pressure, and that kind of sucks that bad air out of the rooms that the patients are in.
Well, that is one good thing. I mean, unfortunately, we have a surge, although it was expected. The good news is it's not this strange, unknown thing anymore. You've all treated it, dealt with it, and know what to do, and know what works and what doesn't. So that must be a little more comforting now.
It is. The volumes are challenging because, again, all of our normal patients are still coming in. So this just adds a level of scrutiny because of the fact you have to segregate these patients because of their isolation needs, because of the contagious nature of COVID. The SARS-CoV-2 virus is just one of the, or 19 viruses, one of these very challenging viruses because of its contagiousness and acute illness. So when patients are sick, they're pretty highly contagious. So, when they got a fever and they're coughing, and it's very difficult. So that makes it difficult because you have to wear all the PPE, and it takes a lot longer to see patients. Plus, the other thing is they're isolated from their families again, and boy, we hate doing that. But it's one of those things where you really have to understand you can't come visit, and that part of the healing process is really very difficult for the medical staff and nursing staff and frontline folks to deal with. We are using technology, and again, we're a lot better. We were in March. We were pulling our hair out trying to figure out how to do this. At least we have things in place now to help with that. But it's still a big challenge, and it's constantly evolving and changing, and we're learning hour to hour.
Well, it's had such an impact on everything. I mean, the economy, and not to mention people that are in long-term care facilities that are isolated as well because of this.
Yeah, the community itself is really feeling this because a lot of the nursing homes where we send patients are blocked up. We can't get patients in there because of COVID. Either they have an outbreak of COVID or they have areas of COVID in there. The penal system's feeling this also with jails having positive COVID patients. And so anywhere there's community living is really just a harbor of this illness. And it tends to reproduce and rapidly spread. Again, a lot of people don't get sick with it. 95% of people don't even really know they have the illness. They're walking around with it and may not even have implications of cough, cold, fever, all those wonderful symptoms. But they still have a potential to spread it, especially with any kind of close contact.
Well, it sounds like we have a couple of months of winter and being indoors where we're just going to have to get through this. But there is good news on the horizon.
There is.
I know one thing you wanted to talk about is there's treatments now that people can actually take at home at outpatient, as well as treatments in the hospital that have been shown to be effective.
Yeah, we're actually engaged. The state of Maryland about 2 weeks ago notified us of drugs called monoclonal antibodies. These are immune modulators, basically, that protect you from a virus of this nature. They basically, if you want to say, they block the virus from spreading throughout your system. They also block the immune response too, so you don't get sick from it. So these immune modulators are great. They're usually fairly pricey, but a couple companies have donated their time and effort to this. We were allocated about 250 doses of the one drug about 2 weeks ago, and we are currently infusing those and have been for about a week. This drug is utilized in patients who are not hospitalized, so it prevents them from being put in the hospital. I think people need to realize this is very unusual for doctors to practice medicine without having good science. Not that this is bad science, it's just rapidly pressured science because we have such a pandemic. We're trying everything we can to help people feel better and stay in the community and not be in the hospital.
Well, when the alternative is death, sometimes that makes the medicine worth the try. So
yeah, and it's one of those things where we're trialing based on what the evidence is. We're using very strict guidelines and protocols, but these drugs are being given. They're actually an infusion where we put it IV in you. It's a one-time dose. Your physicians can refer you to our center if you have a positive COVID test. If you're over 65 or have multiple other medical risk factors, I'm not going to go through all those, but there are certain criteria you have to meet to get the infusion, and it also has to be given in a certain time frame. So there's about a 7-day window of when you test positive, up to 10 days, where if you're not in that window, it's not worth the effort of getting or the risk of getting the infusion. The infusions do have potential to have reactions with them like any other drug we use, so we don't like to use it unless it's truly indicated. So we've infused close to 40 people already in the last 10 days, which is super exciting. And it may be placebo, it may be an effect, but the patients, as we call them back, are feeling better after they get this. And these are folks who are diagnosed in the office. They may be elderly, and we're trying to help prevent them from worsening their illness. So that's very exciting because that's really the first that we have seen a truly effective treatment. Remdesivir has some effects on the inpatients, but hasn't been very impressive. This one's a little bit more impressive with symptom relief, and which is exciting. And I don't want to get too optimistic, but it just feels good to be able to say, yes, we may have something here that will help prevent hospitalizations. And it is not to be used in hospitalized patients. This is just for outpatient.
But that's good if that helps them feel better and they're not coming in taking up a hospital bed.
Yeah, and plus prevention keeps you in your home. And usually about 24, 48 hours, most people are saying that they're starting to feel a lot better from the infusion. So that's a really exciting practice that Peninsula's taken on. AGH has also started their infusions this week, which is really good. So the more of that we can do and partner with them and work with the state of Maryland, we're Region 4, so we have an allocation coming every week. So we hope to be continuing that process as we've seen positive results.
Well, that is exciting, especially to know that it's right here locally, and Tidal Health was on the forefront with using steroids in the hospital, which proved to be very effective. several months ago when we were first facing this.
Yeah.
But the steroids are pretty much just used in the hospital?
So no, we use those in outpatient
Okay.
too. Like I said, some of the nursing homes have had outbreaks, so we're starting those folks on steroids. There's a goal to hopefully use these monoclonal antibodies when we have more of them. It does require a nurse to infuse it. It also requires some monitoring. It takes about 3 hours to go through the whole process. So it's not a quick fix because you have to sit in a chair and let us do our thing. And it really does need to be monitored from a safety standpoint. So it's going to be difficult to do in the nursing home. Steroids are one of those things that really has been effective since day one for us when we started it. And I think it really did help impact our mortality rate early on.
Right.
And then the blood thinners are also still be used in hospitalization. So that typically prevents people from getting blood clots and most other illnesses too. So a lot of new things are coming out, and the monoclonal antibodies is one of these fantastic treatments that I hope we can continue to keep supplying to folks.
And those meds have long names and end with MAB.
Yes, they do. Yeah.
This one is called what?
Bamlanivimab.
Okay.
And then the other one is called Regeneron. Regeneron actually has 2 monoclonal antibodies in it. The Regeneron drug is, we're not using it yet. We will start that next week. We just got a supply yesterday. So we'll see how that one works. And how we choose which one we use, we're learning. We'll be doing randomized studies with the state and being able to send out data on response of those drugs from patients. So it's exciting that we do have something that we actually, I think, could help prevent hospitalizations with. That's a big deal.
Right, it is.
Super big deal.
So exciting, very exciting news. Now I know the next piece of exciting news you want to discuss is the fact that it looks like we have some vaccines ready to go.
We do.
Just in time, because I didn't realize this, but 68 million people have been infected worldwide and 1.5 million deaths from this virus. And now, after months of just hoping, we have some vaccines. So talk to us about that. I know people are concerned about them in a sense because you hear the typical vaccine can take years, and this one has come about so quickly. But reassure us that this was put through rigorous science to get to this point.
Yeah, I think people have a stigma about vaccines. There's a lot of challenges with vaccinations that I think historically have been again, the minority populations. There have been some trials that were done inappropriately over the last decades that again, I can totally understand the reluctance to jump on board with vaccines. Even in doing studies, it's a challenge. This is different though. And if I can explain this in a real simple sense, back in January, the virologist at Hopkins explained it the best, where pretty much this drug or this vaccine, a couple of vaccines actually that we're going to hopefully be getting in the next towards the mid to end of December. These vaccines actually were designed in a week. Were ready for use at the end, or trial at the end of January. I don't think people realize how quickly they can generate that because of this technology. It's unbelievable. This is a new type of vaccine too. It's called messenger RNA, or where they use a part of the cell, the intracellular parts called the RNA, which are proteins that are pretty much help fight or trigger immune responses. Because of that, this new technology is much safer also. So historically, we used to kind of give you the whole cheeseburger to eat with a vaccine. You'd eat the whole cheeseburger, which would include the virus, the cells, every part of it, including the DNA. And we would hope your immune response would only react to it the way it was supposed to. Now we're giving you a very specific COVID RNA protection that can protect you from the proteins that come off of the virus. So the important thing people have to understand, this is a very targeted vaccine. This isn't like anything we've ever seen before. This technology was developed from the Ebola science a decade ago. So messenger RNA technology is really very, very new to medicine. I think people need to realize the reason this was so rapidly developed was because of the funding. There was billions of dollars thrown to the companies who have designed these vaccines to rapidly make large volumes of these vaccines because we were in a pandemic. So in February, March, April timeframe, the Pfizer and Moderna vaccine were both in phase 1 trials where they tested safety in animals. And then phase 2 trials began after that trial ended. And they found they were safe and it wasn't killing animals. Second part, same thing, they did testing. So by July, we had phase 1 and phase 2 trials already completed in 6 months from January. The end of July, they actually started the human trials where they enrolled 30,000 plus people in each trial to get them vaccinated. And volunteers were asked to do it. They were probably paid to do it, but we got them in. And the vaccines have been tested since then and are showing excellent efficacy. What that means is basically these vaccines were showing that patients who were vaccinated had a lower risk of getting this virus than patients who weren't vaccinated. And that's what we're looking for. In fact, 95% of the time was the efficacy in the one trial, that the vaccine protected the patient from COVID. So to me, that just tells me this is a much safer vaccine. Scientifically, it's definitely safer than the DNA vaccines because you're not eating a whole cheeseburger anymore. You're getting something very specific that's targeted. And just by taking away all those extras, bacon, lettuce, tomato, cheese, whatever you put on your burger, now we're just focusing on the one thing. So you don't have the risk of reaction. And we can talk about side effects and go right into that. But there is some noted anaphylaxis risks with anything we do. I can give you a Tylenol,
vaccine,
any
you have
drug.
to sign a form and consent.
Absolutely. Honey, nuts, you can have anaphylaxis from. So people have to realize that's why we tend to give you the vaccine and monitor you for 30 minutes after the vaccine. And those things are very important in the protocol, which we'll be developing as we distribute the vaccine throughout the Eastern Shore.
Now, the first two ones that are coming out or seem to be on the horizon are the Pfizer one and the Moderna one, and both of those require 2 shots, about 3 weeks apart, correct?
Yep.
And they have to be stored under special circumstances, but you all are prepared for that?
Yeah, actually the Pfizer has to be at 70 below zero, so we have refrigeration for that in our system. And then the other one I think is 20 below zero, the Moderna one. Both we're waiting for, there's this thing called EUA, which you'll be reading about a lot in the newspapers. In fact, our monoclonal antibodies are under an EUA, meaning the FDA approved them to be used for emergency use only. And basically it's an authorization for us to use these in humans. So meaning they've done the safety trials, they've approved it, and we're waiting for EUA on both vaccines. Once we get the EUA approval, hopefully we'll get distribution and be able to start the rollout.
And what will the rollout be in terms of who gets it first and so forth?
Yeah, the rollout is pretty standardized in CDC for pandemics. They have a standard which was actually developed prior to Ebola to help with that. Healthcare workers, frontline workers will be first, and they should be. We're at the front line, we're seeing COVID patients. When I say frontline workers too, everybody thinks just doctors and nurses. There's an army that helps me work my day, and these are the people who clean the rooms and the environmental staff, the building material staff, the people who are in the rooms fixing the call bells, and the respiratory therapists, all the other ancillaries, the
Certified
CNAs.
nursing
Absolutely.
assistants, yeah.
There's an army of people who go in and out of that room every day and have been doing it for months with COVID patients, and those are our heroes out there. The doctors are probably in the room less than anybody, and honestly, that group of people should be the first people. So you'll probably see the emergency department, obviously, because they pick up the unknowns. The hospitalists, the pulmonology, critical care groups, and all their support services will be first. We'll be getting probably about 1,000 doses of the first vaccine, hopefully mid-December towards Christmas. As soon as we get those, we're going to get people vaccinated right away. This will not be a mandatory vaccine. This vaccine will be based on if you want to have it or not. So we will not force people to take this vaccine, but it'll be highly recommended, and I'll be first in line.
I know, I would get it too. I think it's really important. And you're saying it's 95% effective, individual protection. But of course, the more people that get it, the better as we proceed through the remaining phases. And I think older adults in congregate living will be next on the list, and then it'll go down from there.
Absolutely, yeah. So there'll be a whole hierarchy. We're working very closely with Maryland Department of Health, and in Delaware, obviously, with Tidal Health and Anacoke, we'll be working with them in the Delaware Department of Health. They'll have strategies around community vaccination processes, and we'll have locations, and a lot of that's still yet to be determined. A lot of that has to do also with the side effect profile of the vaccine, so we can understand that a little better. Most side effects, by the way, in the studies of 30,000 people included local reactions, so same thing you get with a flu shot. And sometimes after you get your flu shot for 24 hours, you kind of got that achy, low-grade temp. That's what's been reported with these vaccines, very low incidence of severe reaction, almost nil. And, again, I think we're going to hear a lot about the severe reactions because of everybody's level of concern around this. But I tell you, this technology is amazing. And I really want everybody to stress that the technology has rapidly given us the ability to do this, but even more importantly, the funding that was given to these companies to develop these vaccines is why this happened so quickly. They've never had that amount of funding pushed towards development of vaccines in the history of the world. And because of that, because of what all the countries have invested in as far as the formulary pharmaceutical companies developing these things for us, is the main reason why this was so rapidly produced. So I don't think you will ever hear a clinician say that we're going to compromise safety for speed. And at this point, I think you're going to be pretty confident that your healthcare providers will be vaccinated first.
Well, that's what I read, that the phases were thorough, but just compressed slightly. And it sounds like a lot of the compression occurred because we already were ahead of the game with this messenger RNA technology.
Absolutely.
And that cut off a lot of time. Then you could just move on to the testing on humans. So
yeah, and there's other platforms being developed and other studies. I think there's a total of 7 right now for the COVID-2 virus that have been put into studies. These 2 are the first 2 to come out. January, you'll probably see 2 or 3 others that have been studied in Europe, Brazil, and Hopkins is one of those trials also. And we're actually partnered with Hopkins to enroll patients in the one trial using the one of the other pharmaceutical companies. So it'll be really interesting to see how this grows. But that's good news because we can feel the goal here is to vaccinate the entire U.S. by the midsummer. So that's pretty remarkable. Considering that would be 18 months after we first saw coronavirus.
Yeah. It's just wonderful that we have Hopkins here in the state of Maryland, too. I mean, they've been the excellent resource for statistics and, of course, clinical trials and such. So that's good news. Also, I want to ask you one last question.
Sure.
What do you say to people that say, we don't know the long-term side effects of the vaccine?
Yeah, they're not wrong. We don't know long-term side effects of a lot of things. So, we use pharmaceutical studies and have for years to drive therapy, and there's many pharmaceuticals we take off the market as research changes. So it's an ongoing, it is a very dynamic process to study pharmaceuticals. We have probably the one of the highest level of pharmaceutical industries in the world in the U.S. And a lot of that is because of the scrutiny of the FDA. And I can tell you right now, I feel very confident that this is not going to stop being studied just because we're giving you the drug. This will be an ongoing study for years and years and years to come. The exciting news is that you're going to see technology this world's never seen before as soon as we get these vaccines. It's going to be technology that hopefully will eliminate this the viral threat that we're feeling right now and bring us back to our world. So maybe next Christmas we can have a normal Christmas.
Yes, that would be wonderful. And of course, the one thing that strikes me about all this, and you have seen it firsthand, the effects of COVID, on people. And that has potentially detrimental long-term effects that we have a pretty good idea about already because we've seen how this virus can ravage the body.
Yeah, there's a lot of research going on about the long-term effects of COVID. Viruses in general, human papillomavirus causing cervical cancer in women. There's tons of viruses at HIV. This technology could eliminate viral damage to humans. There could be preventative measures for HIV in the future. Just imagine vaccinating kids for HIV when they are born. They would never get HIV. They would never have that risk factor anymore. And that to me, just as a physician, number one is just phenomenal, and number two, it's for the community and for the world. We're changing the way we're doing things every day because of COVID.
Well, in general, vaccines have been noted to be one of the best medical inventions ever. I mean,
Absolutely.
we've eradicated, terrible
Polio.
diseases over the decades. So this is exciting news, and I thank you so much for coming on and explaining this and giving us some reassurance that perhaps there's a light at the end of this tunnel.
Yeah, well, thank you. It's great being here.
And thank you for joining us for this edition of Focus on Health here on PAC 14.